Good afternoon and welcome to ICE Webinars, a cool place for hot topics. Today we are joined by Nicole Donraj, Independent Business Advisor and Support Specialist. Just a quick reminder to save the date for our 10th anniversary ICE 2024, which will be held at the Hyatt Regency in Irvine, California from February the 18th to the 20th. The Imaging Conference and Expo is the only conference dedicated to imaging directors, radiology administrators, and imaging engineers. ICE offers valuable CE credits from the ASRT and ACI, and is a unique community of key decision makers and influential imaging professionals. For more details, visit attendice.com. If you'd like the chance to be a presenter at ICE 2024, details can be found in the handout section of your webinar dashboard. And ICE will be exhibiting at the AHRA 2023 General Meeting, which is being held in July from the 9th and the 12th. Again, more details in the handout section. Okay, today's webinar is eligible for one ARRT Category A CE credit by the AHRA. You can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after the completion of today's webinar. You must complete the survey to receive your 1 CE credit, and you'll be able to download the certificate directly from your computer once you've submitted the survey. If you have any questions, you can reach us at webinar@mdpublishing.com. We'll wrap up today's presentation with a live Q&A, so please submit your questions anytime using the questions feature on the webinar dashboard. Let's kick off today's webinar by giving away one of our brand new ICE gym bags to the attendee that can tell me the answer to the following trivia question. April is National Pecan Month. Which state is the biggest producer of pecans? Answer now using the questions feature on your dashboard, and I'll reveal the answer at the end of the webinar. As I mentioned earlier, Nicole Donraj is our presenter today, and she will be discussing the power of dedicated breast CT, why healthcare leaders should consider this innovative imaging option. Nicole, you may begin whenever you're ready.
All right, hello everybody, welcome to this Tuesday evening. I get lost with my days sometimes, but it is a pleasure. I'm just turning on the camera to say a quick hi for those of you who have not met me in person. I am Nicole, and I will be presenting on this hot topic, as Linda says, for the next hour or so. All right, let's see. Okay, so just a quick background about me. I have been in radiology for about 23 years. My goodness, does the time go by quickly? And definitely helping support breast programs and recognizing that there are quite a bit of gaps within our program from the care that we provide. Unfortunately, I've been part of organizations that we have been in the news regarding patients with misdiagnoses, inaccurate results. So I am here today to help share about this dedicated breast CT and why you should consider it. By background, I do enjoy solving world hunger one X-ray at a time, and any opportunity that I see that we can make a big impact for our patients, I like to grab hold of it and share it. So the intent of today's presentation is really to help you understand about this new technology available to help support improved care for our breast patients. Now, as we get started here in the chat, if you can put for me, how many of you actually oversee breast as part of your leadership? And in some positions that I've been, we either did not have a breast program, I had a dedicated breast manager, it was under somebody else's purview. So sometimes it can be quite scattered, but regardless of where you are in terms of that leadership, I think this is some technology that you should be bringing to the attention of your peers to see how potentially you could include this as an adjunct to your current breast program. And as Linda says, as we go along, if you can put any questions or so in the chat, more than likely we'll be right up until the top of the hour. So please put those questions as we go along here. Now, one of the main significance within our industry and healthcare as a whole is that we are always with initiatives that are going to provide increased value to our patient, very patient-centric on improvements. So we're always looking at improving that patient care with the intent of having quality outcomes. We have seen over the last several years, at least from my 20-something years of being in the industry, this has been the common focus. Now, there was a time where we were pay per volume, and now we've definitely changed from that into pay per value. And the intent is, again, that we want to make sure that we are delivering the quality that our patients need for optimal outcomes for them. And we do so by enhancing the value of the service that we provide. But when we think about it in terms of breast cancer, it seems that, again, based on what we're seeing in the news, we seem to be falling short a bit, especially with those misdiagnoses and really not giving patients a clear answer of what is going on. So this presentation is there to help really emphasize that this technology is going to help support these initiatives that we've been trying to go through in the last several years of healthcare, to making sure that we have enhanced outcomes for our patients. As we get going, I want to ask you, are you confident that our current breast services is providing these elements of value? Could you say 100% that you know that your breast program, or even across the nation, that we are really improving the outcomes for our patients? I cannot say so with 100% confidence, especially I deal with a lot of dissertation students, and they're focused on mortality with prenatal, postnatal, breast cancer, all of these societal issues that we see happening. So I am privy to what is going on, especially in the underserved populations. So I cannot say 100% that I am confident that we're capturing as many people to ensure early detection of breast cancer and or making sure that we have appropriate treatment. So we know overall within healthcare that there is a lot of opportunity for us to enhance these outcomes and create value. So again, the intent is to share a potential solution for you. So you heard me talk about some of the pain points, right? Not only it is capturing these patients in rural population, we have additional pain points within our breast program. We're spending a lot of time in research, but yet we're still kind of falling short in the clear answers, or I should say the unclear answers that in some cases we're providing patients. We have seen patients undergo mastectomy, double mastectomy, only to realize it was a misdiagnosis. We're not seeing half of the population, especially in the underserved population. People are not showing back. They're not showing up. We're having callbacks and they're not returning, or they're fearful of more compression, or, oh my goodness, you know, they found something. They don't want to come back for fear of what that is. So we have all of these pain points, and more recently for me, pain points were burning out the staff, meaning that they were trying to get patients added on the schedule same day for the breast ultrasound, diagnostic MR, biopsy. And what was happening, it was creating a lot of pressure on the system, meaning that because we're trying to do these patients a service of not letting them wait, thinking about all the possibilities of what can go wrong, we're instead adding them on to already full schedule that also we have to include, you know, ERs and inpatients on the ultrasound side. So these patients end up waiting a long time in the waiting room, and though we are trying to help them, it also leads to a level of frustration with a long wait time. And then of course that now adds frustration to my front desk, and now my staff is behind hours because the radiologist wants a little bit of a concierge service, meeting and greeting each patient. So it really creates large bottlenecks within the system. And not to mention the scheduling woes, right? We have short staff. Our breast service is typically at least 3 to 4 weeks out. So, you know, it just adds another level of anxiety for these patients who are waiting. And lastly, more recently, we're sending letters to our patients that we're really not sure what we are finding as a result of their dense breast. So it does really add up all of these pain points within our breast program. And as much as my team is dedicated, my manager, she's on top of it, we were still struggling to have improved access, throughput, improved accuracy with diagnosis. So, you know, we're looking for ways in trying to make this better for not only the patients, but overall the staff and the organization. Now, let's kind of take a pause for a second and talk about breast cancer statistics to really drive the point of why we need to start considering potential alternatives or adjuncts for what we currently have in our breast program. let's look at the breast cancer statistics for the 5-year survival rate. Now, as you know, breast cancer is one of the most common type of cancer in women and the second most common type of cancer overall. So we have roughly anywhere between a 10 and a 30% estimate that breast cancer are not diagnosed, unfortunately, until they are spread to the rest of the body. What does that mean? Many women are going undiagnosed until it's way too late. So this information here is drawn from the Susan G. Komen Foundation in Understanding Breast Cancer Survival Rates, and it's really a simplified version to help us understand the importance of early detection. So they categorize the stages into 3 main categories here: local, regional, and distant. So let's look at some of these numbers. If the breast cancer is found in its local stage, meaning that it is localized to the breast, it hasn't spread beyond the breast, there is a 99% survival rate. 99%. If it's regional, means that now the breast cancer has gone from the breast into the nearby lymph nodes, that rate goes down to 86%. And then look at this. If it's now metastasized to the rest of the body, there is a 30% survival rate. So what does that mean for us as healthcare workers? We need to establish programs that we're definitely going to capture these women in the early stages to enhance those quality outcomes for them. The drive here is early detection to help those women ensure their survival. So this helps to really understand, the different stages. Stages of cancer are very complex, right? There's all sorts of factors involved in that. But when we look at it from the local, regional, and distant, it really helps us understand where our initiatives should be focused. Now, fortunately for us in the industry, we've had mammography, which is a widely used modality to help with the detection, increased accessibility. Almost all facilities have a mammo unit or a couple of them to help support the detection of breast cancer, and from that be able to develop a treatment plan. But whatever positive, there is a dark side to it. Despite these benefits, and those are tremendous benefits, despite those benefits with mammography, patients experience significant discomfort from that compression. You have women that don't have any masses, nodules, discharge. Even women without those symptoms, they do experience significant discomfort with compression. Now pair that with a woman whose breast is very tender, there is maybe masses, pain, redness, all of this, it now creates an added layer of discomfort. Mammography has been in the news for misdiagnosis, especially as it relates to dense breasts or even just poor sensitivity for certain types of breast tissue, predominantly with the dense breasts. In addition to this, we have high false positive rates leading to patients getting biopsies and other exams only to recognize that there was nothing because we couldn't trust the mammography exam 100%. So while we have been using mammo, and it's definitely been good modality to provide some understanding of what's going on for the patients, there's also some of these disadvantages associated, as we can see here. And the research has shown us that mammos can actually miss, again, anywhere between 10 and 30% of cancers. And then when we think about it, this is a source of contention for a lot of people when we have these discussions. You know, mammo still uses the tomosynthesis type acquisition for images. When we think of tomosynthesis, even for X-ray, we've seen that that technology has morphed into more 3D isotropic as with CT. So the question lies is, how is it that after so many years, we are still somewhat maintaining that technology? Now, granted, the key here is to recognize that though mammo has been a wonderful tool for us, just like we've gone from X-ray CR to DR, from a 16 slides to a 128 or 1.5 to 3T, a 7T Tesla magnet, it's the same question that we need to ask ourselves. How has the technology morphed over time as it pertains to mammo? It's remained relatively consistent. There has been a few advancements in it, but not significantly as we see with other modalities. Now, in addition to these disadvantages that we see with mammo, one of the main concerns that women don't come back for their mammo is as a result of the negative experience. I wanted to see how many people Google, will my mammo be painful? And look at this. It is astounding, 8.5 million results of people wanting to find out, will my mammo be painful? So what does this tell us? That we continue to compress women, and unfortunately, they are going to continue having these negative experiences, which potentially is going to deter them from returning for their mammo, their future mammos that are. So despite all of these benefits, we're really, unfortunately, we're not able to provide a positive patient-centric experience overall. Patients still come in and, they do the best that they could, and they are happy that we can provide the service. But overall, we're not 100% providing that positive patient experience for them. So unfortunately, not only is it just painful, but there's emotional distress over it. Some people come in and they're worried, they're concerned, there's anxiety and fear, even for having people, and whether it's female to female, touching the breast, manipulating the breast, there is some anxiety and fear as it relates to that. From a technologist aspect, I remember many years ago when I was undergoing the mammo program, and I had patients that I was practicing on. For me, it was somewhat embarrassing. I got a really tiny hand, a very weak hands, albeit, and having to manipulate these large breasts and feeling awkward and doing it, and then wondering, am I getting all the tissue? So you have that other aspect of it from the technical side. So it creates, not the perfect experience for these patients. Not to mention, some patients may just be embarrassed and fearful of what they're going through. So concerning, even though mammo may have its benefits, we're not even going to focus on the disadvantages technically. We're looking at specifically these negative side effects that patients will have as a result of coming in for their mammo. It is concerning because it's going to be a deterrent for them not showing up for their mammograms. And why is that so significant? Because of these alarming statistics. Do you know how many women will develop breast cancer in their lifetime? If you had to make a guess. If you're in the breast program, more than likely you would know, and you'd probably be saying, yay, 1 in 8. I am aware that 1 in 8 women will develop breast cancer in their lifetime. So I look at how many people there are. There's about 20 of us right now here. I can't see faces. So, 1 in 8 of us could potentially develop breast cancer. And again, what we want to focus on is that early detection to make sure that we can increase survival rates, have better outcomes for our patients. So in addition to that alarming statistic, here is another alarming one for us. How many women in the US over 40 do not get an annual mammogram? Do you have an idea of that number? It is a whooping 52% of women. Over half of us over 40 do not get an annual mammogram. And these are for various reasons, but the fear, the negative experience, the concern over it, the anxiety is the main driver for not having a mammogram. Roughly in millions, that is over 40 million women that are not getting their annual mammogram. So going back to our intent as a healthcare industry, specifically radiology, how are we going to ensure improved outcomes, improved quality of living for these women? How do we get them to come back for their mammo? How do we improve the patient experience for them? Now, in addition to just the fear and the concern over mammo, now we have the challenge with dense breasts and mammograms. If you're relatively new to this world, what does this mean? Well, dense breasts can actually make it more difficult for radiologists to detect abnormalities on a mammo. What that means is that it's going to be harder for these radiologists to see the small tumors or any other modalities behind this dense breast. So if we look here, you can see, generally this breast is looking relatively white. Well, if there's anything hiding underneath that, it is going to be difficult to see. So, you know, any type of cancer or tumor underneath that, you're just not going to be able to see it. As a result of that, it means that women with dense tissue have a higher risk of developing breast cancer. And I know some of you on this call may have known dense breasts, and as a result, you have probably, you know, some anxiety within you of, oh my goodness, you know, what is my risk level here? So within the radiology world, we typically describe dense breasts based on BI-RADS number. So you've probably seen that A to D nomenclature to help identify the level of density within these breasts. So here's an example of it, and this is taken from the Mayo Clinic, but from a BI-RAD level A all the way to D. So here you see on the left side, with a BI-RAD A, this is almost entirely fatty tissue. So the breast is predominantly composed of fat, and roughly 1 in 10 women have this type of breast. So if there is any cancer tumors, it's easily identified because of that. We can see through that fat. Then you go to a B level here, which is the scattered areas of these fibroglandular tissue. So you see a little bit of density there, but not as much as, not as much as the C and D BI-RAD description. And roughly about 4 in 10 women have tissue similar to this. And then of course we go to the C and D level, with the D being extremely dense. And then again, about 1 in 10 women have breast tissue that is dense, this level of density, I should say. So if we look at B and C predominantly, those are about 4 in 10 women. So cumulatively, you know, you got a significant number of women in the dense breast tissue area, and you can imagine the level of anxiety and emotional distress that this can cause in that group of women. And when you come, of course, into the D level, it's even more concerning there. So, you know, not only is this concerning just from dense breast is a challenge, but let's look at some statistics here. More than half of us in the US have dense breast tissue. Then, depending on the populations that you serve, and typically we'll see this on the West Coast and in Atlanta, if you're serving a lot of Asian women, 70% of them have dense breasts. And then look at this. Unfortunately for mammo can miss anywhere between 35 and 70% of cancers in these patients with dense breasts. So it is relatively concerning. Or maybe I should change that. It is significantly concerning for our patients that we serve with dense breasts. And this is just not Nicole trying to save the world one X-ray at a time. It is also coming from the FDA, where it does say that here approximately half of women over 40 have dense breasts within in the US. So we are aware that, again, with mammo, we cannot say for 100% certain that we can give accurate results with these women with dense breasts. And the FDA is emphasizing that point, that we really can't, dense breast really influences the accuracy of mammo. So what are we going to do? What does that mean for our patients? Well, if you're in this arena, you would recognize that typically patients that come in for a first time a screening mammo, they'll have their screening mammo, recognize maybe that they do have dense breast. More than likely, they'll go into a 3D mammo and potentially an ultrasound and or an MRI, depending on, you know, how inconclusive those results are. If a woman has known dense breasts, more than likely she's going to come for her annual mammo, which is going to be a 3D, and potentially have follow-up studies based on what the physician recommends. But, you know, we subject these women through multiple tests, but yet what happens? We often end up sending them a letter that looks like this. After reviewing your mammogram examination performed on 1/19/2023, our radiologist has found it to be normal. Yet, we continue, your mammo shows that you have dense breast tissue. Dense breast tissue is common. However, dense breasts can hide breast cancer, so it may not be seen on a routine mammo. It may be associated with increased risk. Now imagine if you're reading this as a patient. The first paragraph says, quote unquote, normal. But then it goes on to say, but by the way, I'm not sure how normal this is because of your dense breast. Now I cannot say with 100% certainty that it is truly normal. It appears normal, but you may have an underlying risk. This is an actual letter that is sent out. And you may be sending out letters within your organization just like this. So when a patient sees this, first of all, there is a level of happiness and excitement, only to be crushed by, there may be a chance that I have breast cancer. And depending on that overall patient's, emotional well-being, psychology related to their health, this may cause significant distress for the patient. And it is significant enough that 38 states within the US here are required to send this notification to the patient as a result of the increased risk for breast cancer based on patients with dense breast. So doesn't this sound discouraging? Patients are probably not going to want to come back and return for another mammogram only to be told the same thing. Why am I going to have a mammo that's going to squish my boobs, and then I have the pain and the discomfort associated with it, only to find out inconclusive? What is the point? This is sometimes some of the decision-making processes that our patients go through. It is becoming even more of an issue and a challenge with dense breast that now the FDA, this actually came out, I think, the first week of March here, the FDA now will require all clinics, all mammo clinics within the 50 states to notify patients whether or not they, to notify patients that they have dense breasts. This is going to be a requirement in the next 18 months here, to let people know that there is an associated risk with dense breasts. So you see the anxiety, the concerns that we have with this population of patients. So we recognize that there is some downfall with mammo, there is some discomfort, there are some challenges with dense breasts. So here is the reason why we need an alternative to have those better outcomes, to ensure that we are providing quality patient care outcomes with enhanced value. So the emphasis here is we need a more accurate and comfortable screening method for our patients, given that we're 21st century and we have the research and development and digital tools ahead of us. Remember again, half of women have dense breasts. So we could potentially be enhancing the outcomes for at least those half of women here. So here's an example that I would like to share with you as an adjunct to your breast program, introducing dedicated breast CT. So let's take a look at what this looks like. I will play this video. There's no sound associated. Hold on a second. This is what happens when I go from pointer, arrow. Give me a quick second here. You should be seeing that right now. So here it is dedicated breast CT. The woman comes, she undresses, she lays prone. Images are taken each side at a time in a complete 360 view here. No compression, easy peasy. Talk about an enhanced patient experience here. So this here is now bringing breast imaging current to what we've been doing in other modalities. So here you have this technology that is capable of giving you some detailed information. And yes, this is FDA cleared, but really helping us utilize the digital technology. Remember, we said breast compression is, will my mammo be painful? Well, here definitely is a solution to help with enhancing that patient experience. So it doesn't end there. not only do we have this breast CT that we can, have detailed and improved images, but now we can also offer a biopsy option as well. And I'll give you some more insights in a second here. So what does that mean? We now have the option of creating some improved images, and let's take a look here. Look at that. Look at the detail, and right where those crosshairs are, you can see that there is a mass of some sort. So really providing some detailed view, this isotropic 3D data set, in order to be able to give accurate information of that breast tissue here. Angela, you know exactly where I was going with this. She asked, does this miss the axillary area? Well, let's continue looking at some pictures here, Angela, and I will show you that in a second. So you're already seeing a little bit of ribs, and I'll bring up some pictures here in a second for you. So with those pictures that I just showed you, you're going to get a true isotropic 3D data set, and we know CT is the gold standard, right? You're able to get your sagittal, your coronals, your axial, these multi-planar isotropic volume data set that we can manipulate in so many different areas in order to be able to get a comprehensive view of that anatomy. And look at this, it's 10 seconds per breast. So it's super quick and easy, again, without that compression here. So definitely improving the patient experience. Instead of the compression, what do we see? Gravity. And this is here. So the patient, you see, this requires special equipment and coils. So it does require a dedicated breast CT, and I'll show you some specs in a second here. So essentially, this CT is predominantly for the breast CT. So you'll have those openings where the patient is going to be able to lay in, just put their breast in. With gravity, we're going to, extend the breast. There may be concerns if the patient has pendulous breasts. You may need to take some pictures above and below, but overall, you're going to be able to get that entire breast area to include the chest wall and the axillary area without any compression. And you may be concerned, oh my goodness, it's a CT, and maybe there's going to be excessive dose. Not at all. The radiation dose is equivalent to a diagnostic mammo. And here is the information that was submitted to the FDA to prove it. So when you look at it, comparatively to mammo, the dedicated breast CT is right on par with that. And in some cases, you can see even lower. So, as we go into further cases and you see a little bit higher level dose, that is accounting for increasing the KVP based on the size of the woman's breast. So let's see some of the dedicated, the benefits of the dedicated breast CT here. Definitely higher sensitivity for detecting breast cancer, which does what? It is going to help with earlier detection, earlier diagnosis for better outcomes. It's going to have lower false positive rates compared to what we've seen before, and it's going to reduce the unnecessary biopsies and other procedures that women typically have to go through. And just as I showed you, that low radiation exposure, we're not going to be overly concerned about it comparative to what we are administering for our patients with mammo. Now, Angela, so here's your question, the coverage. So we can see that the patient we're going to be able to get all of that breast tissue in there and capture the tail of the axilla and the chest wall, which definitely they're not typically seen in mammo. And of course, what does that do? It hides or obscures the lymph nodes just because we're unable to capture that information. And here is the pictures to show you. So on your typical mammo compared to your CT on the right. And here are the detailed pictures to show you that chest wall. We don't typically see ribs on a mammo, right? So here you are capturing that chest wall. You're getting the tail of the axilla significantly into that picture. So the dedicated breast CT is providing excellent coverage of the chest wall, which predominantly is poorly visualized by the mammo. And look at this here on the right, bottom right picture. we can see significant aspect of the chest wall area underlying the pecs. And if you look on the left here, going to get my pen, bottom left, this gray area here is the chest wall. You're not going to see that on the mammo, and then you can see it on the sagittal view here. Here's a chest wall, and there are ribs coming into it. So definitely some enhanced viewing for our patients. And then, of course, having these multiplanar views, you are able to definitely identify any areas of concern, sagittal, coronal, and of course the 3D. So we're specifically interested in that tail of the axilla and of course the chest wall, especially with our patients with those dense breasts. And it doesn't stop there. Calcifications are typically hard to see on those mammos. So here on the left side, we'll see, some speculated areas, but, we can identify that these are some dense areas, potentially calcium. But when we look at the CT here, now we can actually see a little ditzel in the middle there, identifying that there is calcium that we haven't seen with the mammo. So calcium are sometimes an indicator of disease tissue, so it gives a very comprehensive view of the tissue within the breast here. So now we can see not just, from the mammo outwardly here of these calcifications, but now you see a second area of calcification due to the improved resolution with our CT. So it definitely shows that the dedicated breast CT is proving to be beneficial to our patients. Now, let's take a trip over to TSA for a second. If you've flown recently, you may have noticed new technology at the security checkpoint. It is the advent of the analogic Connect CT at TSA. If TSA could recognize the value of CT technology to create these full 3D images of luggage, it means too that our patients are well worthy of having this type of technology in order to be able to get full 3D detailed isotropic data sets for their breast. If TSA can do it, there is no doubt that we can offer this for our patients as well. So with TSA, they're not just, again, looking at these flattened 2D images that they used to. Now they can accurately identify what is in your luggage with these 3D renderings. And look at that. They can rotate it, manipulate it in all different directions with the intent, again, to finding suspicious items through manipulating that data set. Isn't that what we're trying to do for our patients? Definitely well worth the technology. But wait, there is more. The benefits doesn't end there for breast CT. You remember those patients that come in with implants? Well, we no longer need to have implant displacement. Again, gravity replaces the compression, and as such, breast CT is an excellent tool for identifying implant leaks and finding cancers that may be hidden between the implant and the chest wall. So we can see here, again, improving patient experience significantly. Really emphasizing, this has been one of the more painful exams too in trying to displace these implants for patients, but look at that. Just lay prone, place the breast into the opening and capture these images. And there is more benefits. In addition to all that I've showed you, we now have contrast enhanced breast CT. Yes, contrast enhanced CTs are typically the gold standard for cancer detection. And now it is available for the breast, thanks to this dedicated breast CT. So we're able to see this value of it tremendously here with the addition of contrast. And I'll get to your questions in a second. And the benefits continue. In addition to your all the benefits that I just described, you could use CT as a breast biopsy as an alternative to your stereotactic. So it is a valuable biopsy tool and delivers less radiation compared to your stereotactic biopsies. So essentially, it is the same breast, but different technology. And I'll play this for you. Give me a quick second. Here we go. So enhanced value for our patients, being able to truly give a 360 perspective of that breast tissue. All right, so we've talked about all of these benefits for the patient in terms of dense breast, in terms of the compression, in terms of the quickness of it, and accuracy of results. So there are some significant value to our patients. But sometimes these tangible, intangible, even if it's patient-centric care, doesn't always translate into a solid initiative. What drives these initiatives really is also the benefits to the organization. So let's look at what does that look like in terms of the monetary value of it. There are CPT codes, and I'll show you a couple in a second here, but there are currently 6 CPT codes that are approved for breast CT. And here is the average reimbursement. I do know that the slide is a little bit blurry, but you can see the unilateral without contrast is roughly about 219. Then we go with the bilateral with and without, right about 424 roughly. So the monthly reimbursement, assuming anywhere between, let's say, 300 to 400 exams, is right over 100,000 with a yearly reimbursement of 1.3 million. Now, of course, you take into consideration your supplies, your professional fees, but even with that, we still have potential significant revenue here to capture these patients. And the throughput, we haven't even talked about the workflow and the efficiency. I enjoy Lean Six Sigma style and always looking at improving, removing the waste and improving efficiency with the organization. So now here, you can actually have an increased throughput, reduce your backlog, enhance your patient experience. Need I say more? You can see how valuable this technology is. In this case, your patient is going to spend more time in the changing room than actually on the table. So you can actually see maybe about 15 to 20 patients, depending on if you have a tech aid assistant to help you with throughput. So the breast CT, if you're looking into investing in the technology, it is going to pay for itself within 15 to 18 months. So here are some examples of those CPT codes, and I'll be more than happy to send the rest for you. But as you see with the previous slide here, you got the without, the with and the without, unilateral and bilateral exams. So you have that significant reimbursement and value from the organization aspect, and that is where your CFO, your VP of ancillary services, your CEO, they are going to light up. Not only are we helping patients improve the experience, we can potentially capture the patients that are not coming back, those 52% that we're talking about. If you have a patient population of dense breast, you're enhancing the quality of service that you're offering, not to mention you're having a return on that investment with this revenue that it's generating. So then let's look at, if you're thinking about wanting to implement this, what does this look like? Well, the footprint is really small. So here we have a room size of 10 by 14, electrical, your table capacity, table height. So this is a relatively small area. You know, typically when we hear a CT machines, we're thinking, you know, large space, but this could be any room that you can convert, of course, you know, with your shielding and things like that. But the space for it is relatively small and very doable. I stand corrected. I mentioned shielding. That's for your regular CT. With this CT, because the unit is self-shielding, we actually don't need shielding for this. So it's easy to convert a room and be able to add this modality here to help with enhancing your current breast program. So here is an example of a recent implementation. That picture actually was from Brookwood Baptist Medical Center in Alabama. So they decided that they wanted to be a leader in this industry using this technology to help support their patients. And of course, you know, we have the variety of organizations out there who wants to be the leader with the technology. Some people would kind of take a look and see what the investment is, see what it's doing for others before they decide to do it. But they have decided to take the leader stance on it. Now, why did they decide to purchase this first breast CT in Alabama? Well, specifically to the pain points that you have experienced in your own program. The wait time for breast MR. Right now, depending on your organizations, it can be anywhere from 4 to 8 weeks, and more so with the significant shortages that we've been experiencing. These wait times keep getting longer and longer and longer. What does that mean for our patients? Well, if a patient is told that they may have breast cancer and additional exams are now needed, now they got to wait 6 to 8 weeks in order to get that exam. It is going to add a level of anxiety. So in their case, they decided that they want to be able to decrease these wait times, and then not only just decreasing the wait times, but removing this, enhancing the patient experience by removing the uncomfortable breast MR and replacing it with something that is quick and painless for the patients. So remember with MR, and depending on, if that patient is larger breasted, laying prone, difficulty breathing, putting the arms above their head, depending on their size, the way that their neck sits prone comparative to the breast, and staying in that position 30 to 45 minutes is very uncomfortable for the patient. So again, with the intent of reducing the wait time and enhancing those the overall patient experience. They have also been experiencing significant competition from 2 larger hospitals, and the intent was to just create this, they're offering like a spa-like environment and creating this exclusivity around it, really emphasizing the point of no compression. 8-point-something million Google searches, there is some significance with that. They also recognize that, gosh, the return on investment is less than 2 years. For something as valuable like this, it seemed as a no-brainer for them. So when they presented it to their C-suite and it was evaluated by their senior leaders, their breast surgeons, the technologists involved, the managers, it was definitely the way to go for them. So this is one of their marketing videos that I'd like to share. So here we have the audio, sorry, is not working, but Brookwood Baptist in Birmingham, Alabama. They're the first in the state to offer this breast CT. And the intent is here that it is going to be recommended. It sounds like my video has paused. There we go. So recommended this new technology for detecting breast cancer with this breast CT for those who have a history of dense breasts, abnormal mammograms, additional imaging that may need it after a mammo. They can now utilize this breast CT with no compression, quick 10 seconds per breast, and a full 3D image. So it's definitely been a selling point for them, and of course wanting to be amongst the first to provide this enhanced value for their patient population. In addition, they're also using this as a marketing tool as well. Compression free. Again, we saw from that 8-point-something million patients that patients are really looking forward to not having their breasts compressed for a variety of reasons. So do you remember when the Da Vinci robot came out and it was like, this was the thing? Well, this is exactly comparing to the Da Vinci robot here. Now, you can advertise this to your patient base and definitely capture those patients to enhance the value, to enhance the outcome, and of course, the patient experience. So the breast CT is a unique opportunity to have something tailored specifically for your market. And they actually put this billboard out in front of one of their competitors. And you can imagine somebody seeing this, what does that mean to them? This creates significant negative impact on a woman's psyche. So this is a fantastic tool for them, not only from a revenue generation, but providing a social quality service to the patient population. So what are the major goals that you're seeking in your program? Definitely, you want to have these better outcomes. You want to avoid having your organization in the news about misdiagnoses. We want to reduce these lawsuits. We want to improve the patient-centric experience. We want to provide accurate and precise results, especially for our patients with dense breasts. So having a technology like this can definitely help make a dent and really help provide services that we can capture these early breast cancer in its early stage, localized to the breast, and as such have improved outcomes for those patients, and of course increase the survival rates. So then I thought again, well, how many people are talking about early breast cancer detection? Look at that, over 90 million. So we recognize the value in early detection. So why not have a service that you could now use as an adjunct to your current program in order to provide this early detection with the intent of increasing quality outcomes and survival rates for our patients. And as the quick Google search here says, the best prevention is early detection. So you've seen all the benefits. Again, just as when we've had a variety of modalities come out with new technology, our radiology director leader sensor should go up and say, whoa, why should I consider this? Well, we've identified that mammograms are an important tool for detecting breast cancer, especially for women across a variety of ethnicities and age groups. But we see the missing links here, predominantly with dense breast and the compression side of it. So potentially you can utilize that the dedicated breast CT to help fill this void, to help with the improved outcomes for these women across the US, and not to mention have a return on investment there. With the key goal, again, we're driving value, we're enhancing patient care with improved quality outcomes. When we have traditional breast cancer screening methods that we've been used for decades, and yet we're in 21st century and sending out these letters which says, there is a risk of you getting breast cancer, it really doesn't sit well. We have so much technology. We are really pouring money into research and development as far as the breast cancer world, yet we're not being able to provide super accurate diagnoses for them. So the dedicated breast CT technology can offer a more comprehensive approach to breast cancer screening and definitely serve as an adjunct. We're not saying to replace mammo, but using it as an adjunct to your current services. Before we get into the questions, I will leave you with this. You don't know what you don't know until now somebody's educating you about it. But I think Maya Angelou says it best. Do the best you can until you know better. Then, when you know better, do better. So now that we are educating ourselves about potential technologies that are out there, I strongly urge you to consider just having a chat. I'm more than happy to sit with you and talk more about my experiences of how we can do better for these patients. Questions you can ask: how do you capture patients that don't return? How do you improve financial performance in your breast program? How do you improve patient experience and reduce your no-show rates? No-show rates significantly affect our departments. How do we reduce the headaches and anxiety for patients, especially with dense breast? And how do we increase survival rates with better outcomes? So now that you know better, please feel free to reach out to me. I can be more than happy to set up an appointment with you and have a chat more about this service and how you could implement it if you are looking to provide an adjunct, and especially to improve your patient outcomes. So thank you for your attention. I have a few more minutes here. I do see a long list of questions that I would get to. If I'm unable to get to your questions, again, let's spend a few minutes just talking about this and seeing how you and I together can solve world hunger one X-ray at a time, or in this case, one dedicated breast CT at a time. Miss Linda, I'm just going to go through the questions here as we wrap up, okay?
Okay, no problem.
All right, so Angela asked, what is the cost versus standard mammo? And Angela, I'm assuming you're asking about the cost of the equipment, or is it the cost of the actual exam? If you can clarify for me. How long does it take? How long does a breast CT biopsy take? And does it require off like other exams? Yes, and that's why you have the CPT codes available there. So you are going to have authorization. With traditional, oh, is it run by CT techs or mammo techs? So you can actually have the either your CT tech or your mammo tech trained to do this. Yes. Now, ideally, your CT techs, they already have understanding of the technology. So they would be the ones who would be the easier techs to train on it, definitely. For the patient, so I'm assuming, Angela, you're talking about the reimbursement here. So we can go back quickly to that slide. So the reimbursement, as I said, it could vary from anywhere between the 200, and instead of going through like this, let's go back, to 474 is the range of the reimbursement. And I'll be more than happy to send this out for you as well. So the unilateral, you should be seeing that right now. It's about 219 compared to if you're doing bilateral with and without at 400 plus. Let's see, with traditional mammos, ultrasound is often an adjunct. Do you see this being the same with CT or no longer needed? Well, Angela, I can tell you, yes, so right now you do the mammo, potentially you can add on that ultrasound, and now you're taking up an ultrasound spot. And even that, you know, you still may not get conclusive results. So now I would see this freeing up my techs. I have those inpatients, the add-on outpatients, all sorts of stuff I'm running behind. So you can use this as an adjunct, definitely, or even just as a replacement for dense breasts. So for example, and I have, you know, high level understanding of this in China, again, their population is, of course, you know, predominantly Asian women. So they already know that their women are mainly dense breasts. So they're bypassing the initial mammo, or they're bypassing mammo, I should say, and instead of doing that and getting inconclusive results, just having the CT. So you can choose how do you want to use this. It could be as an adjunct, a supplement, an alternative. There are multiple ways that you can use this to help with that throughput and alleviate the pressure. So now that you can free up that ultrasound or that MRI slot for other patients other than, you know, just adding these breast patients onto it. All right, let's see, what questions did I miss there? How many companies manufacture a dedicated breast CT? So as of now, there's one that is FDA cleared on the market right now, and that's offered by Koenig. Definitely be able to share more information for you if you want to have a follow-up and see if this would be a good supplement for you. All right, I think I've gotten through the questions there. Linda, do you see any more coming in on your side?
No, I think I've sent them all to you, so I think we've covered them all. I can squeeze in one more question for you from an earlier.
Okay, sure.
How do I integrate breast CT into a well-established breast imaging program?
Yeah, so there are multiple ways to go about that. And I think the biggest, or I guess the scenario that you can look at is identifying your pain points. What are your concerns? What are you trying to enhance as far as your patient outcomes? What initiatives do you have currently? So if you recognize that, you know, let's say you're on the West Coast and predominantly your patient population is dense breast, and now you're sending out these letters and you're recognizing that your callbacks or your return patients are decreasing, then definitely you can use this as a supplement for those dense breasts. As you can see, the footprint is relatively small, so you don't necessarily need to have a large construction. So your established program, just break down where the pain points and identify how you're going to use that breast CT, and then just looking for an area where you could put it in. And again, that 10 by 14 room, so it shouldn't be significantly difficult as it is with implementing a new CT or an X-ray room there. And again, you know, you have, instead of shuffling your patients, so right now your established program may be that you're shuffling patients to your ultrasound or your MRI, so you don't necessarily need to do that. And not to mention, you may be losing some patients that you can't get an MRI because they have contraindications, they can't lay flat, pacemaker, implants, all of these things, insulin pumps, all of these contraindications that are typically, you know, deterrent for the patient to get MR. And also, you know, some patients are relatively concerned about, you know, all the literature that they've been seeing on Google regarding getting those gadolinium-based injections. Or so it could be integrated in any manner, relatively easy, but really starting with identifying your pain points first to see what you're looking to solve. And of course, you're going to have the revenue there. And the biggest value here too is that we're seeing that, you know, it's attracting the patients from your competitors. So if you're in a market that, you know, you have significant competitors around you, like I showed you with Brookwood, and you want to be the leader in the industry and just kind of filter your patients, I mean, you're going to capture a lot of patients just by knowing that they're not going to have compression anymore. And now that, you know, we have a lot of this information that's going to be circulating on the internet, you know, patients are doing Dr. Google these days. So if they recognize that there's an alternative without compression, you bet they're going to be packing your bags to go to that other facility.
Great. Thank you so much, Nicole, for your time today and for a really great, informative presentation. Very, very thought-provoking there. As promised, the answer to today's trivia question is Georgia. So congratulations to our winner, Jay Streeter. A quick reminder, you can obtain your CE certificate by completing the post-webinar survey, which will be emailed 1 hour after we've finished today's webinar. You must complete the survey to receive your 1 ARRT Category A CE credit by the AHRA, and you'll be able to download the certificate directly from your computer once the survey is submitted. If you have any questions, you can reach us at webinar@mdpublishing.com. Visit icewebinars.live for more details of all our upcoming ICE webinars and, of course, complimentary registration. Thank you once again for your time today, and we hope you enjoy the rest of your day.
Thanks, everybody. Looking forward to more discussions. Thanks, Linda.
Thank you.